Our next question is actually, in today of 2020, should a patient consider traveling potentially a long distance to a center of excellence for beam radiation treatment, or has radiation technology and, I guess, personnel development of who's doing this radiation for local centers and local options, would that seem adequate?
Yeah, my thinking is evolving on this. When IMRT first came out at the Cleveland Clinic in 2004, we would send people back to Cleveland, and it was certainly worth it. The patients did extremely well. IMRT was a giant breakthrough back in 2004, 2005. And then as the people in Los Angeles learned how to do it, we started referring locally. We have, in our experience, because we refer a lot of radiation therapy out of our practice every year, have seen a difference with centers of excellence that do a lot of volume compared to some of the private centers that are out in the small community areas. And it's just a sense that the chances for side effects is less if you go to a large volume center. There's no doubt some excellent doctors out in the community that do equally good work. It's just hard to know who they are. And since radiation is a one-time thing, and if it isn't done properly, it can leave you with lifelong issues, we're still pretty picky about where we send our patients for radiation.
Yeah, I think talking about the volume in any treatment, it's something that we always are pounding the drum with PCRI, so it makes a lot of sense. Our next question is in regards to possibly radiation causing new cancers. So is it possible to know how often radiation treatment causes new cancers? And is there any particular form of radiation that's more likely to cause it?
This is one of the attractions of brachytherapy, of course, is that the radiation doesn't have to be beamed through the body to hit the prostate. And it appears that the incidence of secondary cancers is very tiny with brachytherapy, almost immeasurable. There is a difference with older radiation, where the beam radiation wasn't very accurate, and there was a larger area around the prostate that was exposed. And there were, over a 10 to 20 year period after the radiation, there was a very small incidence, well less than 1%, of people that could get secondary bladder or rectal tumors. There's a sense that this is being further reduced now because IMRT and SBRT are becoming so precise, and there's very little overflow of radiation around the edge now. But there is still, we monitor patients, and we've had patients getting IMRT, as I mentioned, now for over 15 years. I've seen one patient who developed appears to have developed a secondary bladder tumor out of the, who knows how many thousands of patients we've referred. So it's a very tiny risk, but we generally recommend that people get a urine analysis once a year to look for blood. And then if that's present, we order something called a CX bladder, which looks for bladder tumors. And after 10 years or so, 5-10 years, we'll start doing an ultrasound of the bladder wall, make sure there's nothing suspicious there.
So our next question is in regard to radioligand therapy. So first of all, before I ask the question, can you explain what Xofigo and Lutetium are?
So these are types of radiation that are given by injection. It's like a smart bomb that circulates through the bloodstream, and then the radiation coalesces around the tumors in the bone or the lymph nodes. And the Xofigo exclusively for bones, which is a derivative of radium, and then the lutetium, which is not FDA approved yet, is a monoclonal antibody, and it will clip onto prostate cancer patients' cancers just like PSMA PET scans do. So if they're in the lymph nodes, the bones, or other sites, it brings the radiation right to the cancer.
Well, in regards to that, so our question is radioligand therapy, like you just mentioned, Xofigo and Lutetium, a reasonable option for a patient who's already gotten the maximum amount of radiation that they can?
Yeah, there's people that have had radiation to their prostate or lymph nodes or even to their bones, as long as they don't have a depleted immune system, which you measure with a CBC. Look at the white count, look at the platelet count, make sure there's no excessive anemia. Those things are extremely rare after people that have had standard radiation for prostate cancer. If actually doesn't occur at all. But sometimes men with very advanced cancers where their bone marrow has been weakened or they've had a lot of previous chemotherapy, they may not be able to get Xofigo or Lutetium-177. But most people, it's not an issue at all.
My next question kind of goes into the cost. I know we've talked about, the different types of side effects of radiation and also, traveling and the convenience of it. But is there any form of radiation that is more cost effective than another?
Permanent brachytherapy seeds are the most cost effective. It's a single treatment. And so I think economically, I'm not an expert in the economics of radiation, but shorter courses of radiation, because the radiation therapists do bill by the visit. So people that only get 5 visits, it's going to be less expensive than people that get 20 or 30 visits. So I think that the economics of seed implants are very attractive, and this is why seed implants are becoming more popular around the world as time goes on.
I know in a previous video we talked about brachytherapy, and one of the reasons it's not as popular is not many doctors do it due to the reimbursement issues. So you had mentioned that there's a possible change coming in Medicare coverage. Is there any update in that?
No, it's the people that work for Medicare that make these decisions say that it's coming. I don't know if we'll see that in 2021. We certainly look forward to it. Doctors are incentivized by profits, and the doctors that give IMRT are paid so much better than the doctors that do seed implants. If they could bring those on a more even basis, then we'll be seeing a lot more seed implants, because the literature, the scientific support showing cure rates and side effects show that it's an excellent way to treat people.
So, talking about seed implants, it has been said that temporary seed implants are preferable for a disease that may have spread beyond the gland, since it can be placed around the prostate. But would that still matter if the patient has already received beam radiation?
I think it would be a matter of degree. The permanent seeds are ideally placed in the prostate. So if there's, for example, clear-cut spread into the seminal vesicles, the temporary seed implants, where they use the radiation through a catheter that can even be put up into the seminal vesicle, that's a better approach. So when we're talking about disease outside the prostate, sometimes it's just theoretical, high PSA, or maybe there's an MRI that says maybe the edge of the prostate looks a little bit ragged. Permanent seeds are fine with that, because they put the seeds up near the edge of the prostate and they emit radiation for about a half a centimeter outside around the gland. But when you have a situation that shows up maybe on a digital rectal or an MRI, that there's obvious large amounts of cancer that are growing outside the prostate, I think that's where the temporary seeds are more appropriate than the permanent seeds.
Is there a preferred form of radiation for salvage therapy after radical prostatectomy?
Almost all the data is with IMRT, so that would probably be the safest, more traditional approach. There's preliminary data with SBRT, and the proton doctors have their protocols as well. So I don't know that there's a preferred form, but when you look at all the literature and the data, it's almost all IMRT.
Thanks for watching. If you would like more information, you can visit our website at pcri.org. Also, subscribe to our YouTube channel. We come out with new prostate cancer videos every week.